This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Fluids and Barriers of the CNS, titled Clinical Characteristics and Outcomes After Shunt Surgery in Idiopathic Normal Pressure Hydrocephalus, with or without prior cerebrospinal fluid tap testing.
This is a topic that hits home for anyone who spends time in the hydrocephalus clinic. We all know the classic triad: gait disturbance, cognitive decline, and urinary incontinence, paired with ventriculomegaly. But the million-dollar question has always been, who do we shunt? And specifically, do we really need a CSF tap test for everyone before we roll to the OR?
Exactly, Dr. Aris. This study comes out of the Sahlgrenska Academy in Gothenburg, Sweden, and it's a massive single-center follow-up of 481 patients. They really dug into the real-world efficacy of the cerebrospinal fluid tap test, or CSF-TT, as a predictive tool.
Now, before we dive into the data, let's set the stage. The CSF tap test is ubiquitous because it has a high positive predictive value. If the patient improves after you pull 30 to 50 cc's of fluid, you're pretty confident a shunt will help. But the paper points out a major flaw: the low sensitivity and low negative predictive value.
Right. The risk is that we might be excluding patients who would actually benefit from surgery just because they had a negative TEP test. This Swedish team used a multi-professional, team-based diagnostic algorithm to see if we can streamline this.
So walk us through the two groups they studied.
They looked at 481 consecutive patients. They divided them into two categories. First, the no-TET group. That's 390 patients. These people were shunted based solely on typical clinical symptoms and MRI features, like enlarged ventricles and normal CSF pressure, without any supplementary predictive testing.
And the second group?
That's the TT group, 91 patients. These were the cases where the diagnosis was more uncertain, perhaps due to atypical symptoms or comorbidities, so they underwent the CSF tap test and were only shunted if that test was positive.
It's worth noting the scale they used to measure success. They used the Gothenburg iNPH scale, which I find much more comprehensive than just checking a modified Rankin scale or a walking speed. It covers 4 domains: gait, balance, cognition, and continence.
It's a 0 to 100 scale, where 100 is normal. For this study, they defined improvement as a post-operative increase of at least 5 points on that total scale at the 5-month follow-up.
Okay, so let's get to the baseline. Were these two groups starting from the same place?
Mostly yes, but there were two very significant differences. First, the TT group, the ones who got the tap test, had a much higher prevalence of concurrent neurological conditions. We're talking 37% in the TT group versus only 11% in the no-TET group.
That makes sense clinically. If a patient has Parkinsonism or significant vascular dementia alongside their hydrocephalus, we're naturally going to be more hesitant and reach for that tap test to confirm how much of their deficit is actually shunt responsive.
Exactly. The second big difference was the timing. The TT group had a significantly longer delay between diagnosis and surgery. The median delay was 198 days for the tap test group, compared to only 126 days for the no-TET group.
That's a 2-month difference. In the world of NIPH, where we know early intervention is key to reversing symptoms, those 2 months of waiting for testing and confirmation could be critical. So what happened 5 months after the shunt was placed?
The results were quite striking. In the no-TET group, the ones shunted based on clinical and MRI features alone, 70.9% showed improvement. In the TT group, that number was significantly lower, at 58.6%. That's a percentage point difference of 12.3.
That's a statistically significant difference, p equals 0.044. But wait, let's look at the other side of the coin. What about patients who got worse despite the surgery?
This is where it gets even more interesting. Post-operative deterioration, defined as a 5-point or more decrease on the NIPH scale, was significantly more common in the TT group at 22.9%, compared to just 10.6% in the no-TET group.
So the group we were more careful with, the one where we insisted on a positive tap test, actually had worse outcomes and higher rates of deterioration. At first glance, that sounds counterintuitive. Why do you think that is?
The authors dive deep into this. It's likely not that the tap test is bad, but rather it's a reflection of the patient population. The TT patients were difficult cases from the start. They had more comorbidities, like other neurological disorders, which limits their improvement ceiling and makes them more vulnerable to deterioration.
And don't forget that surgical delay. The paper mentions that the time between diagnosis and surgery was a factor. If we spend months doing supplementary tests on a patient who already meets clinical and MRI criteria, we might be allowing their condition to progress to a less reversible state.
The researchers actually ran an adjusted analysis to account for those concurrent neurological disorders and the surgical delay. Even after adjusting, they found that improvement in urinary continence was still significantly better in the no-TET patients.
This is a vital point for the residents listening. Continence is often the last of the triad to appear and sometimes the first to improve, but it's very sensitive to the overall neurological health of the patient.
They also looked at the modified Rankin scale, or MRS. Before surgery, about 53 to 54% of patients in both groups had an MRS score of 3 or higher, meaning they required some help with daily activities. After surgery, 40% of the no-TET group improved their MRS score by at least 1 point, whereas only 27% of the TT group saw that same functional improvement.
So, if I'm a resident in the clinic and I have a patient with clear DESH, disproportionately enlarged subarachnoid space hydrocephalus, and a classic magnetic gait, what is this paper telling me to do?
The study suggests that for these high-certainty cases, you can routinely proceed to shunt surgery without a predictive TAP test. Their team-based approach showed that 80% of their total iNPH cohort could be identified and treated successfully based on clinical and MRI features alone.
It really challenges the idea that the TAP test should be a gatekeeper for everyone. The authors essentially argue that the TAP test should be reserved for those difficult patients, the ones where the diagnosis is truly uncertain.
Right. Using it as a mandatory screen might just lead to unnecessary delays and potentially exclude false negatives who could have improved. They mention that their approach, shunting based on high clinical suspicion, leads to high response rates overall.
I want to highlight the team-based aspect they mentioned. This wasn't just one surgeon making a snap judgment. This was a multi-professional team assessing gait, balance, and cognition. That kind of rigor is what allows you to bypass the TAP test safely.
Exactly. And they didn't just look at gait speed. They looked at the whole Gothenburg iNPH scale. Interestingly, the gait and balance domains improved across both groups, but the no-TET group had that edge in continence and overall scale points.
Let's talk about the limitations for a second. This was a single-center study, though a very large one. And since it wasn't a randomized control trial, the groups were inherently different. The TT group was selected to be the more complex group.
True, but that's also the strength of the study. It reflects real-world neurosurgical practice. It shows how we actually use these tests. We use them when we're unsure. The study confirms that even when the TAP test is positive in those uncertain patients, their outcomes aren't as robust as the classic iNPH patients.
It also serves as a reminder that NIPH is often a plus disease. It's NIPH plus Alzheimer's or NIPH plus spinal stenosis. The presence of those comorbidities, which landed them in the TT group, is a major predictor of the final outcome.
The authors conclude by saying that a majority of NIPH patients can be shunted with favorable outcomes without supplementary predictive testing. They suggest that the TAP test is best reserved for those suspected NIPH patients who present with concurrent neurological disorders.
It's a call for efficiency. If the MRI shows the typical features and the patient is stumbling and forgetful, don't let the lack of a TAP test hold up a potentially life-changing surgery. Get them on the schedule.
And monitor them closely post-op. Even in the no-TET group, about 10% deteriorated, which reminds us that shunt surgery isn't without risks, and NIPH is a progressive condition.
This has been a great deep dive into a very practical paper. For our listeners, the take-home message is clear. Trust your clinical exam and your imaging. The TAP test is a tool for the gray areas, not a hurdle for every patient.
Definitely. If you want to see the specific point breakdowns of the Gothenburg iNPH scale, check out the full text in Fluids and Barriers of the CNS.
Thanks for joining us today, Alara.
Always a pleasure, Dr. Aris.
And thank you to our listeners. Keep practicing, keep learning, and we'll see you next time on the Neurosurgery Hub podcast.